Hello, welcome to another episode of the Project Purple podcast. I'm Dino Verrelli, founder and CEO of Project Purple. We have an exciting interview coming up with a very special guest after a few quick updates. Since 2010, we've contributed over $3 million and counting to pancreatic cancer research efforts. We've also allocated over $1 million worth of aid to more than 1,300 patients and families through our patient aid programs. Your monthly or one-time gift can improve patients' lives through research and assistance programs. You can donate now at projectpurple.org. Pancreatic cancer does not rest, and neither will we. Your support is truly appreciated. If you're looking to get involved in one of our many events, whether that means joining a run team, participating in a virtual run walk, group fitness, golf, or anything else you can think of, visit projectpurple.org/events to learn more. Without further ado, let's meet our special guest coming to us all the way from the wonderful state of Illinois, a recent recipient, say recent, like the most recent recipient, I should say, of a Project Purple research grant, in particular, the Rick Carone Early Detection Grant, which is a grant here at Project Purple, which is named after a longtime, really close friend of the family, Rick Carone. This grant is made possible because of the support of Project Purple and also the Team Carone Foundation, which is Rick's family, which supports this grant financially as well. Associate Professor, Department of Medicine, Division of Gastroenterology and Hepatology, College of Medicine at the University of Illinois Cancer Center, Dr. Paul Grippo. Welcome to the Project Purple podcast, Dr. Grippo.
Yeah, thanks, Dino. I appreciate the opportunity to just chat and have a lively discussion about what's going on in the world of pancreatic cancer research and how that impacts people's lives.
Well, thank you for taking the time. I know we were playing catch up before we hit record, and we're super excited to have you on. As I said, the last really like 5-6 years has been kind of a tipping point for us in terms of, funds raised. And we've been able to put a lot of money back into research. And you've been in this game a lot longer than we have. As we were saying, this is really an exciting opportunity for us and for you. We've got to put the work in. We've got to support researchers. I've always said, that's our job. Our job is to support researchers like yourself on the front lines. I get super geeked out when we bring researchers on because you guys are literally on the front lines. And I've said this, I'll say a lot of things, Dr. Grippo here on the podcast. Like I get really excited because I say I have the best job in the world. And I truly believe that. I'm not like sugarcoating that or trying to make something up here because I get to talk to the patients and their families, our participants. But I also get to talk to the researchers. And until we started this podcast, that was like really challenging, like how to articulate, like having a conversation with a researcher. Now that we've had this podcast for almost like the last 7 years, it's great because you get to speak it, we get to record it, and, we play it. And we don't have that challenge anymore of articulating that. So I just get really excited. We've had a lot of researchers on recently, which is awesome, because I like to say that there's a lot happening in this space. I know for the families out there that are going through this, they need results and need, research to happen a lot quicker. But we've got to put the work in order to get to where eventually we'll have better treatment outcomes. So I'm just super excited to have you on. Not only you're our recipient this year for the Rick Carone research grant, but also another person in the field that we can bring on and share all the great things you're doing. So with that, I'm going to hand over the microphone. I'm going to stop talking here. This is your opportunity to share kind of your background, what got you into the space, how long you've been doing it. And with that, the microphone's yours.
Great. Thank you. Appreciate the introduction. And I'll just go back to training, early on in my career path. So, following 4 years at Oral Roberts University, I spent a couple of years working and then got into graduate school at the University of Wisconsin up in Madison. And we were up there probably longer than we thought we'd be, nearly 10 years up in Madison, and had a wonderful time there. Of course, there's always struggles along the way. That path, the path to pancreatic cancer was a little bit circuitous in the sense that it wasn't a direct line. So I started out in the Department of Biochemistry, and I remember the first first day or two that I walked down the halls of one of their older buildings, and I saw these individuals on the walls, and these are people that I read in textbooks, their discoveries, and they were done there at the University of Wisconsin. The biochemistry department is pretty notorious for having outstanding investigators, a lot of vitamin research. And I remember feeling good about myself until I went down that hall and I felt really small, Nobel laureates and, authors of books and, oh my gosh, chemical reactions named after them. And I came out of the room like this big, out of that hallway, thinking, how will I ever make it? These people are phenomenal and I'm just me, which speaks to the whole idea of what you've done, Dino, in regards to raising funds. This is not something that an investigator does solely, because even if federal grant, foundation grants, someone's supporting the work and it's not us. And we can't do the work without the funds. And so what you see regardless of where it comes from, whether it's tax dollars that go to the NIH or donations that are going to foundations, these are the lifeline of what a researcher relies on to get the job done. And it does tend to be very expensive. So I've learned through the years that it's teamwork. And when you have that isolationist view, it's me trying to figure this out, and you walk down a hall of those that have done it before and did it very well, you tend to think, how can I do this? But you get built. Unfortunately, graduate school helps you build up the tool set that you realize I can do this. So I was there for 8 years, and I got my master's degree in biochemistry, and then literally went around campus looking for a home to do my PhD, and landed in the lab of Dr. Eric Sangren, who was over at the vet school. And so here I am with a bunch of DVMs learning about pancreatic cancer. I wasn't even aware you could get cancer in the pancreas. That's how naive I was. And I remember the first conversation I had with Eric, he was like, well, you got a lot to learn. And I mentioned this before, but Eric had one of 3 R01s at the time that were strictly focused on pancreatic cancer in the nation. This is back in the probably mid 90s, he was awarded it. So it was rather peculiar that I was on this, and I thought, well, let's make the most of it. Well, when I saw the numbers and how poor people responded to therapy and all the things that, many of you who have had a family member go through this, it's a pretty difficult path. And reading some of the stories and actually never meeting anyone. By the time we set up meetings, those people were gone. And so it drove me to say, this is not acceptable. This is not good. And so began that long track. I've never left pancreatic cancer since a graduate student. So that's what we're talking about, approaching 30 years now working in pancreatic cancer. From the University of Wisconsin, I finished my degree in 2000. I did a wonderful postdoc 2 years at the Medical College of Wisconsin, and I went from a vet school to a department of surgery. Now, I do not have an MD. I am not a clinical oncologist. I am a researcher, but I work in very clinical settings, which I think is just appropriate for what I want to do. I want to impact human health. I think a lot of questions are fun. A lot of questions are important, but the questions that matter to me the most are the ones that impact human health. And that's kind of where this project came. So after 2 years there, I was 12 years at Northwestern University. Again, that's when I started doing a lot of diet studies. And we did consider early detection as something that we wanted to chase, but we never had great fortunes. We didn't, when you have an animal model, and that's essentially what was developed when I was at the University of Wisconsin. It was an animal model that used a human gene, and we drove pancreatic cancer in a human gene. Now, I say pancreatic cancer, actually what we developed was an early stage disease model. And with one gene, when you add another oncogene, a cancer-causing gene, you end up getting pancreatic cancer. So as the initial model, it doesn't go on to cancer, but it develops some very strange lesions in the pancreas. And we started using that model to test with diets to see how diet would impact the development of disease. And we've been predominantly focused on fat and what fat does, particular fats. We focus primarily on polyunsaturated fatty acids. And I do say we because it's a team effort, right? This is that includes funders as well. It's a team effort to get this done. And so over the years, we've had a lot of fun discoveries, some of which surprised us. Some of which I can give you an example of our latest, one of our latest. It's a challenge to figure out what's going on. I can give it to you very simple. When we feed animals a diet enriched in what I call fish oils, these are omega-3 polyunsaturated fatty acids. But as you know, fish oils are very healthy for the most part, as far as fats go. And we compare that to a diet that's enriched in corn oil, which is omega-6 polyunsaturated fatty acids. These are cousin fatty acids. They're not that different, but it's a matter of positionings of some bonds in the structure. Regardless, they behave differently. And it turns out that your corn oils and vegetable oils tend to be more inflammatory, and your fish oils they oppose the inflammation to a great degree. So we did this study, and we found that, as we expected, animals that were fed the corn oil diet did far worse than the animals that were fed the fish oil diet. Now that seems, very straightforward. So, okay, we're right in our hypothesis and the data supports that. And we were thrilled. Now we wanted to know why. And that's where the story kind of takes some crazy turns. The latest one, I won't share all the details, but the latest one that we're really focused on is the omega-3 diet has always been, that fish oil diet has always been anti-cancer. However, if you play with the genes a little bit, suddenly you can have omega-6 and omega-3 behaving the same way, pro-cancer. And we were shocked because that fish oil diet was always anti-cancer. So there are some genes that if they get modified, they kind of nullify the effect of a diet enriched in fish oil and take that advantage away. So now we're trying to investigate, to our surprise, which genes and what's happening. And we found that liver health actually impacts to a great degree how people can respond in their diet. If their liver's compromised early on, and this can be an effect from diabetes, it can be an effect from overweight or obesity, then that could indeed impact a diet that would be very favorable to fighting pancreatic cancer, basically taking it off the table. So we're trying to figure out why that's happening. So that's kind of where I took that idea. That was right when I was crossing the line between Northwestern and heading to UIC, University of Illinois in Chicago, and then became part of the University of Illinois Cancer Center, looking at these diets. And now we're looking at, like I said, we're kind of focused on liver health and what that happens if you have a fatty liver or compromised liver. Number one, the diet may not be effective if you start nutritional aspects of treating any kind of cancer. We're opening this up to all cancers. Again, we're using pancreatic cancer as our model, but this could be something that affects all cancers. The other idea is that maybe it affects therapy. If you give therapy, typically you're hoping that the liver will be able to work with the drug that goes on board. It's going to metabolize it. It's going to work with it in some way, either favorably or not favorably. And if the liver can't do its job favorably, the drug might not be useful. So you're taking a drug and it's not having any impact on the progression of the disease. It continues to advance. So those are the things we're interested in. And like I said, the early detection piece fits very well with the modeling systems that we have. We can test it. This is actually a device, and I know we'll probably talk a little bit more about that, but we're excited about that because we've gotten some very good positive results just with a cancer model. So we now have a true pancreatic cancer model, and we also have the early stage model. We have both, and it allows us great latitude in the work that we do.
It's awesome. So the light bulb just went off for me. Ironically, I just was listening to a podcast about these whole, related but not related, but it was two scientists actually at Stanford, and they were talking about this whole, they talked about health and nutrition. It was more about nutrition, but the topic of Ozempic and Mounjaro came up, and these, weight loss drugs that are out on the market. Not that we're going to talk about that here, but the light bulb that just went off, and just because I've been listening to this podcast and you talk about like diets and stuff like that and how that impacts. And I know we've had some people on, that have talked about this at a high level, about certain diets, like you just said, like impacting treatments, right? And, there was a company that we brought on, a pharmaceutical company that had a approach to clinical trial where, if they would sequence the tumor, and then based on that sequencing would determine like what diet was best for the treatment protocol that the patient was on, potentially. So, but my question here, and the like, my eyes got kind of big here, is like, this is what you're doing now. Have you ever looked, when you look at diets and you look at these models, like have you ever looked at like, okay, so if we look back 50 years, like the diet and the things that we were using, like, corn oils weren't a thing, right? Like these seed oils weren't really a big thing like 30 years ago in our diet, as much as they are today in our diets, I guess. And same, maybe it could be retrospectively that fish oils were probably more prominent then because that was readily available, right? Like the lards and oil from fish. But then there was this like industrialization of like these the corn oils and the seed oils and everything. Has there ever been a study that you've seen maybe that can like, I mean, I guess it'd probably be really hard to do then, maybe just thinking, talking through this out loud, like retrospectively looking back like 30 years ago at the diet, or is there a way to do that with mice and what a model potentially?
Yeah, I mean, the nice thing about diet studies in mice is that what you give them is what they eat.
Yeah.
And that's the biggest advantage, right? You can do it in human. The problem is you give them a questionnaire, like, what did you eat in the last 24 hours? Or what did you eat in the last 72 hours? I'll be honest, I'd have to really dig hard to think about all the things that I ate in the last 72 hours, right? And so accuracy is an issue, but we talked about, you mentioned the notion of AI. And so AI can, to some degree, try to help correct what might be problematic when you do a human study. But there are dangers there because the biases that are there with people are still there when because AI is just making an algorithm that when you feed it the data, well, if your data is skewed in a particular way, well, that's what you're going to get back. It's going to be skewed. So we don't get rid of biases with AI. And I think that's what people think happens. It does not work that way, unfortunately. But it can help to some degree accumulate enough where we can get better definition of what's going on in human studies as well as mice. What I'm saying is that, and I'm going to bring this into the equation, Dino, in regards to, we're working on a model. We've toyed with it and we know it works in part, but we're trying to create a pig, a pancreatic cancer model pig. Yeah. And the reason for that is manyfold, but in particular, with a pig, it's a larger animal, right? Its anatomy and physiology is more like that of human. And from an immunological standpoint, we use pig parts in people.
Correct.
So there is that link. And the reason I bring that on board is I think you do a diet study in mice, I think you can learn conceptually. And yes, with a pig, you'd learn conceptually as well. But I think because you're closer to the human anatomy and physiology, the data you get is going to be closer, as we would imagine, to that of human beings. So I think the diet studies, the advantage that we have is that we can really control what the animal eats, and we can also collect stool, we can collect blood. And when you talk about a pig, that can be done routinely. With mice, getting stool is one thing. Getting blood is a whole nother thing. You just don't get a lot of blood from, the animal has such little blood, you can't keep taking blood from it. Well, if you have a 200-pound pig, you can take blood every week. You probably take it twice a week if you wanted to. So there are tools available now that we're beginning to extend. And the reason I mentioned taking stool, as gross as that might sound, we're interested in the microbiome. We're interested in the bacterial component of the GI tract to know what's different and what signals did receive to make it different and what does it do during disease progression. And there's been some fantastic work, actually several years ago now, even out of New York University, that really highlighted not only the microbiome in the GI tract, but also the bacterial component in pancreas itself. Fantastic work that was done. So that avenue is well. So what I'm saying is there are a lot of tools that we could do this. The difficulty is, of course, in the design of the experiment, but it can be done. It just takes some thought to come up with the right way of doing business.
Yeah. The toilet diagnosis apparatus has been talked about often on our podcast. We've had a couple people actually, survivors that have talked about this. One lady in particular And one gentleman, actually, lady in the UK, she wrote a book about understanding your poo. I think she called it like poo in the loo, I guess is what they call it in the UK. But I mean, we're laughing about it, Dr. Grippo, but she was absolutely like dead serious. And then the guy here in the United States was like, yeah, like he actually, I think went steps to like, he's an engineer. Like he looked at like, okay, how do you do this? Because to your point, like, I mean, there's so much fascinating data about that, understanding the stool and like, that being like an early indicator of like what's really going on. I mean, not to get like, I mean, I know this is like early Monday morning and we're talking about stool, but like there's so much to learn from it, right? Like even like look back at COVID, like they were examining like what was in sewers, right? Like to determine like where COVID was, like in terms of like from a standpoint of like how large like the population in that certain area was, because they were looking at like urine samples, right? And so like your waste, what you excrete out of your body, potentially could be like the holy grail, maybe, I guess we could say. I know that's kind of far-fetched maybe a little bit, but that's not, I think, crazy to say, right? Like, oh, look at someone's stool to determine like their gut microbiome, like what's going on, like what's really underneath the hood, just like you would a car, right? Like mechanics do this every day, all day. It's kind of like hypothetically the same kind of concept here, like getting in underneath the hood of someone's body and seeing like what's really going on.
Yeah, yeah. I mean, think about it. A car is a great analogy, or any vehicle. And I know that there's this transition to battery operated, but
Yeah.
for a car that's combustible, you put gas in, but you're also going to at times get an emission test, at least in the state of Illinois. I know many states have this as well. You get an emissions test, right? What comes out does matter. Is the car functioning well enough to collect the waste that comes out, so that what's being dumped out isn't so carbon heavy? I get the concept. But it's the same with any organism, really. And if I'm doing diet studies, I can't just do diet studies and not try to measure what comes out. To me, that's a failure to really understand, because there's a process that we're measuring. And if you have normal mice versus abnormal mice, right, ones with pancreatic lesions and cancer, what's the difference? And if you control rigorously as much as you can, and I don't want to get into a discussion about controls, because I can pull apart any control because I've learned how to do that. We say, well, if they're all the same and they're in but if they're in separate cages, that's a whole different ballgame. It's like people in their own homes have different stress levels, right?
Right.
And so you can't just equate, but at some point you have to just draw the line and say, well, I don't know that information. And we can look at that. So we're actually also interested in stress. That's our newest avenue. This is a colon cancer project, but we want to bring it into the realm of pancreas. It's how does stress play a role? And it turns out stress and diet are really close cousins. They like to work together, as it turns out, at least in colon. And we have a hunch that it's probably similar in pancreas. So yeah, I'm very pancreas centric. Any experiments in my group that we're doing for colon, I tend to think, how can I bring them into pancreas?
Pancreas. I
So
love it.
that's, and the reason why, it's funded for colon. So I have to go in that direction.
Of course,
right?
of course.
But
Yeah.
I use conceptually, I can say again, I can take the concepts and bring them into pancreas and nurse that in a little bit, or keep it on the warmer until I get funds to chase that down. But that to me is fascinating, and we have to think long and hard. And we do a lot of work with health disparities. That's another thing that's really going to UIC and UI Health has opened my eyes to a city that is fairly segregated in the city of Chicago. And now we're positioned really with our patient population. We can iron out some of these differences in the different demographics, ethnicities, and races that are seen in our patient population.
I love it. I've got to go back to, I got one question here, and then we're going to talk about the grant, but I want to go back to, you landed in Dr. Sangren's lab. And this question I ask often when I bring researchers on in the space. Was there a case? I know you mentioned, walking through the halls there and seeing all the names and, but was there, I guess, like I call it kind of a tipping point that said, you know what, this is it. I found my home. I know hindsight's always 2020, but maybe there was like an exact time in that kind of timeline where you said, yep, this was it. This was the reason, this interaction or this thing happened to me. And this was just like this was the catalyst that set me on this path?
Yeah, that's a great question. And I work a lot with students, as you could imagine. Students, trainees, some have their PhDs, some are on their way to getting their PhDs, some are still in undergraduate programs. And what I try to tell, what I preach to them is this idea that you want to be at the intersection of opportunity, passion, and skill set. What are you really good at? What are you passionate about? And what opportunities fill that void? So, Dino, to a great extent, Project Purple has provided opportunity for me to chase down something I've been interested in for a while. And it meets my skill set, working with rodents as an expertise, but knowing the ins and outs of doing animal research, and passion. Now, the passion is interesting because you would say, well, you were impacted by pancreatic cancer in your family. No, until my first cousin passed away last year from pancreatic cancer. Now it's very personal. This was, he was about 9 years older than me. So it wasn't that we were really tight, but, you go to family events and you see each other, and he's like the big brother you never had, right? And he was stolen from us, right? And so now this is a more personal thing. So the passion has changed over the years, but there was a click. There was a moment, and I should say this, that when I was looking for a PhD home, I visited 40 different professors, because many of them didn't have funds for a graduate student, or they didn't have room in their lab, or they were trying to figure out what they might, a lot of times they said, well, I didn't know what you were looking for. I don't really have anything to offer. So I reached out to 40, and the 40th was Eric Sangren. And he happened to have a grant that no one was working on, and it happened to be in pancreatic cancer. I go back to this point of it being divine. I did not make that happen. It came to me, but my skill set met the need, in the sense that when I started there, turns out that I was really good at cloning genes, which is what predominantly we did to make these animal models. Well, then I had people from all over campus coming and say, hey, can you clone this and you clone that? And I remember one time my PI came in, he goes, what's going on here? Is there a deli counter out here? Why is there a line out the door? People, I'm paying for this. And I'm like, well, no, I'm just trying to help him. He's like, look, I agree with helping other investigators, but we can't do it to this level. So we had to kind of shut it down. So when your skill set and the opportunities start to line up, this whole idea that, Project Purple came on with an initiative that had begun years prior is to me, and people are like, how did you design that? How did you get all those players together? I did not. That is strictly, from my faith, that is strictly something that God put together for me. Yeah. And I walked into it. That's opportunity. You can't make opportunities all the time. And so I say skill set, opportunity, and passion. Passion is the key. And when I started working on pancreatic cancer, I knew I need to be here in this space. I mean, there was no, let me look. So everywhere I went, I unusual path. I did my graduate work in pancreatic cancer. I did a postdoc at medical college in pancreatic cancer. I went to Northwestern and did another postdoc in pancreatic cancer. I got an appointment in pancreatic cancer, and it just continued from there. It never. Most people that do training, they jump from project to project. They might do cancer, and then they're doing inflammation, and then they're doing, orthopedics. I mean, they can literally jump around. And my path, when people say, wow, you never explored anything else. To me, there was no need to. I hit what I knew was the nail on the head.
When you said that, that just telling that story about the 40th, and like, I got chills thinking about that, because, it's like, you just never know. And hopefully maybe for some young researchers listening to this, I think society today, like certain individuals, especially the youth, look at social media, and social media just shows the successes, right? It shows the guy driving the fancy car, whatever industry, right? We can even say this in our industry, right? Like in this space. But they never see that the misses, or the no's, the rejections, and you just got to keep hammering away, and good things will happen. But I love that, the passion. If you have passion and the skills, like, you're going to go far. You just got to have that right opportunity. And I have a lot of sayings. It's never, luck isn't about just being in the right place at the right time. It's like being ready when that opportunity presents itself, and you got to do the work. as we said before we hit record here, is, putting in that work, and something that we're super excited to be able to help researchers that are super passionate like yourself do the work. So let's shift gears here and talk a little bit about, this Rick Carone grant and what it's about for our audience listening at home. And I'll just quickly, as I mentioned in the opening, Rick Carone was a good friend of ours. Was very young when he was diagnosed, battled like a superhuman for many years. And upon Rick's passing, even before he had passed, we had made a decision here at Project Grippo to establish a grant in the Chicagoland area. Rick was all about Chicago. He was born and raised in Chicago, was a big baseball player, and played professionally within the Chicago White Sox organization for a little while. And so before his passing, we talked with his family and him, and we thought it would be really important, especially with our growth in the Chicagoland area. I know we mentioned, we were talking a little bit before we hit record about our 5K in Park Ridge. We're a big partner in the Chicago Marathon for now since 2014. We also participate in the Chicago half marathons in the spring and the fall. No pressure here, Dr. Grippo, to run, by the way.
Oh, you'd be gravely disappointed. That's not my skill set, That's out of my skill set.
No, it's all right.
I can walk it and I can bike it, but running,
yeah. There's no pressure here. I am throwing out a lot of running, but so
I can come out and cheer though. I'm happy.
Yeah, exactly. We love that. So we established this grant, and we've been really fortunate to be able to fund some researchers in the Chicagoland area. Because of COVID, there was a break here. Now we're back, and you're this year's 23-24 recipient. So let's talk about the grant and what you envision and what the vision is for the grant.
Great. I'll tell the story version because it's like I said, it's very amazing how all these pieces fit together. I have to go back to the pandemic. Just at the start of the pandemic in 2020 is really where the story takes shape. Like I said, I always had a vested interest because I had a model. I just didn't know what to study in regards to earlier detection of pancreatic cancer. Again, we could look at blood, but as I mentioned before, blood from a mouse is very limited. You get such little bits. It's not helpful for doing those type of analysis. But actually at Northwestern, we did look at some blood, and we did, again, nothing terribly interesting. And it was, expensive work that was funded by the university that eventually it was just, we were struggling to get anything that was different. So early detection was on my radar, but I didn't feel that I had a good modality to test. And so in 2020, two things happened. Well, actually, I started working with a company called Novascan in Chicago, a small biotech company. That's prior to the pandemic. But we were just working in regards to, I didn't know exactly what they did. We were working in regards to some toxicology studies and supporting the work and using mice for that. And then suddenly the investigator who was working with me mentioned a device that they were working on. And they were testing it already, and it seems to be working in other cancers. And I said, well, let's try it in the models. And that started prior to the pandemic. And so we were just kind of toying around with it at the time. And a colleague of mine, Kareem Watson, who now works for all of us for the NIH, so he's on a national platform. He really kind of took me under his wing when I started at UIC, taught me a lot about health disparities. And he contacts me one day. He's like, yeah, I've got a state senator and a state representative, and they want to do a pancreatic cancer bill. And so I told him about you. I'm like, okay. And all of a sudden I'm getting contacts now from the staff of State Senator Johnson, and State Representative Ammons. And I was like, okay, what's going on here? Well, they put in a very short, brief 2-sentence part of a bill. You can imagine a bill is just thousands of pages, right? And everyone's got their little bit of whatever. But this is very interesting. What they basically said, and I don't have it word for word, it was very nicely said that if we had an early detection modality, we want to make sure that we would roll this out in the community most impacted from pancreatic cancer, which are African Americans. And it's worded much better than what I'm saying, but it meets the disparities issue, but it also has that early detection. And here I am playing with a device going, could this be part of that? And so I was going to be a witness when the bill was passed in 2021, but they took a vote before they had me talk. And maybe that was to their advantage because they said, you got to keep it to 2 minutes. And people that know me, 2 minutes talking is that's an introduction if I'm lucky, right? Yeah, you're laughing, Dino, because like this guy can talk. So it turns out that that's where it all started. And working with their staff, the bill was passed into law. And essentially, from what I understand, it kind of puts the insurance companies on notice that if we get an early detection modality, you're going to have to come to the table in some manner to help. And so that's the foot in the door. They would then have to pass more legislation, but then they said, okay, now you've got, and I've got this device that at the same, roughly the same time. So that was passed in 2021. We started getting more data and information. We published our first paper this year in regards to pancreatic cancer. My question was, can this detect the earlier lesions? And that's where Project Purple steps in. Because I said, okay, we could do this, but I'm going to have to use animals that don't get cancer. And I'm going to have to find patients, human patients that don't get cancer per se. So we're looking at a model and we're going to do it in the rodents, but we're simultaneously going to be doing it in patient populations. So individuals that have chronic pancreatitis or get diagnosed with chronic pancreatitis, roughly about half, maybe a little less than half of them get what we call PANNs. They get these early pancreatic lesions that can lead to pancreatic cancer. Now, for people that hear this, they probably would flip out if someone said, well, you got lesions on your pancreas. They're probably thinking, I got cancer. Actually, more than that, you don't. These lesions form, and we find that in upwards of 30 to 40% of all individuals that are older. There was a German study, and now more recently done here in the U.S., that if you look at patients that don't have any cancer, and let's say they're in their upper 80s, they pass on, and you do it on autopsy, if allowed, permitted to by the family, you would find that in the pancreas there are these lesions, and they're more prominent than we thought they would be. Like I said, 30, 40% of the population might have these lesions, but they sit dormant. They're, it's like a skin tag, right? It's not going to do anything to harm you, but it's there. Potentially, some of these could advance, and that's the question we're after. We have a device that we think would be like a rheostat. It would essentially give us higher numbers, like a true blood biomarker. The higher the numbers, the more progressive the disease is. And then we have to determine using the animal model, where is that break point? And then conceptualize it when we start looking at our human population that have chronic pancreatitis. Again, about half of those will have the lesions. And what we're going to do there is just do a simple study in regards to, okay, we'll use our device, then we'll hand it off to the pathologist, and the pathologist will tell us what they see. And we have to see, does our device inform on the stage of early disease? If they see these lesions, and in half the patients they will, what stage are they at? So these PANNs are marked by 1, 2, and 3, with 3 being the critical one that can advance. Having PANNs 1 and 2, as far as we know, doesn't mean it's going to progress. Now, again, we don't have perfectly firm data in regards to that either. Everyone's like, oh, that's for sure. Well, in science, I say for sure is a real hard place to be. We're confident that PANN 1s can advance to 2, and 2 can advance to 3. But we don't see PANNs 1 and 2 that advance to cancer either in rodents or humans. But that doesn't mean we may have missed it. And that's all I'm going to say. So that this grant is perfectly positioned to address the question of, can we detect early disease and the stage of that disease? Is it 1, 2, or 3? Three's pretty. We got to have some conversations with a clinical oncologist at 3. 1 and 2, we would probably suggest, well, we need to follow this more routinely to make sure they don't advance or get larger.
So in theory, then, Dr. Grippo, then is this, well, let me back up. So we know we've done some stuff in the genetics early detection space of high risk. So we know just that there's, I think, 6 or 7 genes. I think it's 7. That, if you have these genetic markers, that if you're in screening and surveillance, like your risk factors go up for, various cancers, pancreatic being one of them. So BRCA, for example, we know with BRCA 1 and 2, there's a higher risk. So now we've supported that effort. And that would be, they say anywhere between 5 and 10% of the cases here in the United States come from this genetic predisposition that these people have. And then we've done some work now in the IPMN space, right? There's these IPMNs that, again, 5 to 10% of these cases, again, just because you have an IPMN, just because you have, these pannins, just because you have a genetic risk doesn't mean that you are going to get cancer. We just don't know which ones, right? But if we do know, if you pick people in surveillance and screen them, hopefully that you get these people at earlier stage cancers versus, later stage cancers. So if we throw the genetics and the IPMNs, let's say we'll just use round numbers, 10%. So that's 20% of the population. And then there's this 80% of just they call as like sporadic risk, right? People that get this disease that we just don't know why. Would these pannins then be in that 80% potentially? So is this like I even think I know there's maybe 5, right? Because like you mentioned pancreatitis, which, there's a certain percentage of people that eventually may get the disease, not everyone. Right. But then there's also the type 3 diabetics, which is kind of that new diabetes class over the last couple of years that potentially, but that's like a precursor, I guess we could say. So maybe there's like these. So would this pannins be that like that in that 80% of sporadic risk is what we're talking about population wise potentially?
Yeah, we're focusing on pannins and that essentially kind of a non-genetic. Now, remember, these animals are genetically altered. They do have a RAS mutation. That's what drives the lesion. So we are using that model. So, but individuals that have a RAS mutation strictly in the pancreas, yes, they have a higher risk, as you mentioned, pancreatic cancer. But again, it doesn't mean that everyone, in fact, more than not, they won't. I mean, that's the dilemma. However, they should be screened. So I did mention that right now we're working with this device. We call it this device ex vivo. That means we're looking at the tissue once it comes out of the animal or the human patient. Correct. What we want to really do, and I say we lightly, I mean, this is something that Novascan has been designing, is potentially put it on the end of an endoscope so that during an upper GI routine endoscope, you could actually use the device as a measure of what's going on. Right now, typically what's used is called EUS or ultrasound, endoscopic ultrasound. And the ultrasound will give you a picture. And ultrasound has improved greatly over the years. It's not like just, looking at something like, I don't even know what I'm looking at, but a good radiologist can see a whole lot with that. The problem is we're relying on seeing something. And what we're thinking is that this device might inform on changes that happen at a molecular level that haven't manifested in a cellular level. So you won't see it, but you'll start to see the numbers going up. We feel it could be an earlier detection than doing EUS. Now, to do EUS in a person, you can't just take any random person, right? And say, well, let's look at random risk. You have to game the system, right, for those that have higher rates of pancreatic cancer. And that is indeed one reason why we're looking at African Americans, because they have higher risk for pancreatic cancer. But it's more than that. We have to be smart and look at the genes to try to decipher. You can imagine if individuals have pannin lesions that have chronic pancreatitis, you would assume that they would have a mutation in RAS. And in many cases they do, but there are some lesions that form and there is no RAS. So that's rare, but there's always a caveat to the things that we do. We have to be sensitive to that. So that the goal is to ultimately consider a device. And this is one reason that we're interested in a pig model, as I mentioned, because you can't do EUS in mice.
Yeah.
Just can't do it. You'll kill the animal. So we could do it in a pig model very easily, as if we were doing it in human. In fact, surgeons and endoscopists train on pigs. Yeah. So it's a very valuable model, and that's something that, in fact, we just late June we submitted a pre-application for this endeavor at the Department of Defense, and we're waiting to hear back from them about chasing that down, because that could marry very nicely with the information we get from this project to say, let's bring it into a larger. We got good evidence that this is working well. Let's bring it into a pig model and go in that direction so that we can begin to get it closer to a clinical trial.
It's so awesome. I mean, my head's spinning a little bit because I got a couple of things here, but I think it's just so inspiring, Dr. Grippo. Again, like we said before we hit record, I mean, this is the work that has to be done. This just hasn't been done, right? And I think that's part of the frustration as a patient advocate is like, we want, and I'm sure for families, I guess I'm necessarily not speaking for families here, but I'm sure they could relate to this is like, hey, when you're in that fight, like you want everything, right? Like you want all this advancement, you want all this technology, all these advances, we want better treatments, better outcomes, but we've got to put that work in. And like we said before, I just don't think like these things, these amazing ideas, these novel ideas just haven't been done yet. So we've got to fund researchers like yourself to be able to do this. I come from a for-profit side, and one of my main inspirations naturally was my dad when I started Project Purple. But I also looked at it. I came from a finance side, and I looked like the numbers. I'm like, there's nothing in this. Like, comparatively, my mom's a 2-time breast cancer survivor. I mean, that's $1 billion industry. Pancreatic is like maybe like 200, maybe now we're scratching the surface at like 250 when you take philanthropy, NIH, and maybe the public sector, like maybe we're scratching like 250 million, here in the United States, maybe. But that's a big difference. We're breast cancer is 4x what we are. And I know a lot of people in the advocacy space always try to compare, and not just pancreatic cancer to breast cancer, but like all cancers to breast cancer, because breast cancer did make that, massive jump. They get a ton of funding, but it also is a higher incidence, right? Like there's over 250,000 women and men that are diagnosed with breast cancer every year, whereas pancreatic cancer, we're hovering around 66,000. But when you look at survivability, right, like it's a stark contrast. And sometimes I feel like that's a hard example for us to follow, and we've got to kind of carve our own path. But we've got to fund research. We've got to fund researchers like yourself. So thank you for all you're doing. That is just so, I get so jazzed and so excited because this is like where the rubber meets the road. You're on the front lines, and these great ideas. I say a lot of things. As I said, I remember first time I met with a researcher. I won't mention his name, but we're in his office in New York, and I love whiteboards. He had this whiteboard almost as big as I have one here in the podcast studio, is like 6x10. We took a whole wall of it in a whiteboard, but his whiteboard was that big, and he had all these ideas, Dr. Grippo, and he's like, I just need the funding. So I've always said, like, since that conversation, it's never there's never a lack of ideas, as as you've kind of certainly displayed here on this podcast in the last, almost 50 minutes here that we're talking, but it's about funding. And this is, I think, the critical piece is like for people watching and listening, why it's so important to donate to Project Purple, PanCan, Lustgarden, whoever you're donating to, as long as that money's getting back to research, it's just so critical that we continue to push and continue to raise more funding and provide more funding for research. So super excited. I got a couple questions left here for you. These last couple questions I always say are loaded. There's no right or wrong. It's given your experience. So don't face any stress or pressure in what the response may be. I give you a blank check. Like, where could we make the biggest impact in early detection given your experience? Like if you had like, hey, there's a blank check, like these are like my top 3 initiatives to like really push early detection and maybe raise that needle or push the needle from, a 13, 12% survivability to like 30, 40% in the next 5 years, where would you do that?
Yeah, so I mentioned the pig model. I mean, I think that's a big ticket item as far as funding goes, because housing a mouse is one thing. Harboring a pig is a whole nother ball of wax, and it's terribly expensive. However, I think the utility of a few pigs over dozens and dozens of mice makes sense. I'm not abandoning the mouse work at all. I will continue to do that from a genetic standpoint. It's very important. However, I think if you want to have more human or translational impact, you have to move into that realm. Having a platform like that will enable us then to collect blood and stool routinely. We can do it on a weekly or even more than weekly basis. Why? When we did talk a little bit about the stool and what we can learn from the stool, we could also do the diet study while we're trying to measure the detection device. We could look at blood and see what blood correlates with the increased frequencies that we see with the device. So we can begin to open this up, and because there probably are some good blood biomarkers. The problem is they show up, a lot of them show up late, just like the symptoms. We want biomarkers that show up, maybe they show up and then they dissipate when the cancer is already high enough. We want those markers because those will be early detection. Yeah, there are some markers that might go up and stay up, and then they never really represent disease. So I think The blood biomarker area, I have a postdoc that she finished up in my group and is now an attending, she's now a assistant professor back in Spain, and she's still interested in those blood biomarkers. And we always visioned, and she's going to have a student late this fall come and join us to do that very study in mice. Again, collecting the blood, which is a one-shot deal if you need a lot of blood from a mouse. But that's a very important study because we can correlate disease progression with what markers she's seeing before there's ever cancer on board. And I think those are very important studies to do. How do we do them in human? Well, we've recognized that chronic pancreatitis can serve that to some degree, but at 50%, you have to take enough patients to do that. We can do it in a small kind of pilot study, but that needs to be opened up more readily. And I think it has to be multi-institutional. Because pancreatic cancer, as you mentioned, is a fairly rare disease, but it's extremely lethal, we need to work in teams. So I do know folks at University of Chicago and, of course, at Northwestern that we can do this. We can get our patient volumes high enough and representative of the type of patients we're looking for across the board. And I think these are very important studies, but they require a lot of work. They require a lot of people to organize and do the work, but also to, when you're talking about patients, just working with IRBs and all the regulatory issues you have to face, rightfully so, that you need people to do that as well. So all that adds up to, to some degree is a fairly large price ticket. But we can do some pilot studies to show it's worth going in that space. And I think this particular grant will certainly serve that purpose and give us the rationale for expanding it into a larger animal platform.
I love it. Question that just came up in hearing you speak. Has the pig model, I've heard about the pig model before. And I know they've used various, pigs and various other cases and other cancers and stuff like that, and valves and valve replacements and stuff like that. I've read about that. And usually you hear about the mice, right? Like everyone talks about mice, my mice lab and all this stuff. Is it purely economics when it comes to the pig model versus a mice model?
Well, it's more than that. The care involved, a pig is a USDA model. In other words, we have to have USDA approval where mice are not. So there's a regulatory issue that goes along with this. A larger animal requires obviously more feed, more care from staff. That includes veterinary staff and space. Space in Chicago or any big city is going to be very expensive, just like rental costs, right? Yeah. So if you need a large room for one pig or two pigs, guess what? They're going to charge you the room weight as if you put in 500 mice. And that's what you look at. We have a few alternatives, but when you want to do the work and have your lab at the ready, you have to bite the bullet and pay the price to have the animals there. But it's not purely economic. It is to some degree. It's what you can do that you can't do in mice. If we work in a team effort, when you get a sample, imagine getting a pancreas the size of a human pancreas, and you can now, we call it bread loafing. You can take the whole pancreas out and go section by section. We can use all these new technologies that I call them the large data sets for transcriptomics and protein evaluation and mass spec, all these wonderful tools we now have. We could begin to do that on a slice by slice basis and have other investigators saying, well, we would like a slice or we would like two slices. So in other words, you could archive the tissue, the blood, the stool, and others that are interested in maybe other aspects of pancreatic cancer could look at it and do their work and maybe get some good preliminary data to say, we now want to move in that realm without necessarily bringing the pigs to them because of the cost involved. Yeah. So that's where economics might pay off. Yes, initially it's economics. It's a lot more money, but down the road, I think when we have teams working together and saying, "Oh, can you collect this, and this for us?" Well, sure. The charge for collecting tissue is a lot less than actually generating and housing the animal. Yeah. So we envision this as being. We do have a business partner that they're the ones that the OncoPig comes from, called Sus Clinicals. They would be instrumental in helping us. They do fee for service. You'd much rather pay a fee than bring an animal on board, even with mice to some extent. The problem is you just don't get a lot of tissue or blood or stool from them that you would get from one pig.
Well, and listening again here, Dr. Grippo, it's like collaboration, like you said, right? Like if you have these collaborative efforts, then you can move the needle. And that's something that we've been really as I said, funding research and trying to encourage collaboration with some of our larger projects, because that's critical. I think that's critical. No one is ever going to be the person, I think, to like solve this by themselves. We need collaborative efforts, and we've got to continue to encourage that, which we can from a funding standpoint. So that's something that I take to heart, making sure that our large scale grants, do include that collaborative effort, so that more people can learn from what someone might be doing in their lab, wherever they may be based. It's exciting. My last question here, and then we're going to hand it back over to you to just share where people can learn more. Maybe there's a funder out there. Maybe there's families in the area that potentially want to learn more about all the great things you're doing there at UIC. This is always our last question. Again, it's a loaded question. There's no right or wrong, but given your experience and what you've done over your lifetime here, what's your definition of pancreatic cancer? How do you define it?
Oh boy. Yeah, I've got a lot of words for pancreatic cancer, some not very pleasant, as you could imagine, because of that passion part that we talked about earlier. It's a crazy, evil disease, mainly because the symptoms that show up, they're uniformly late in the disease progression. You're at a stage 3 or 4. And that's hard for any cancer, and it's particularly hard for pancreatic cancer. There's a lot of things we can learn from pancreatic cancer that would apply to many other cancers. So funding pancreatic cancer research is essentially funding a lot of other cancer research. I think that's important. And I mentioned this as well. We have skill sets. If I don't have a skill set, I probably know an investigator that does have a skill set. So the team mentality is really big for me. I mean, I promote that with my group, but I promote it even with, in the institution. And I try to keep, some ties with others at other institutions, because we all need to work together on this. So I think I took the answer in a different direction, Dino. If you want to realign me, you're welcome to step in and realign me. But I really believe that a team effort, and it's hard because, we all are competing for the same dollars. And so there is the competitive nature of, you want your grant to do the best. I recognize that this was a very competitive grant. The fact that it was limited to the Chicago area certainly gave an advantage to those in the Chicago area, but still made it competitive. So I recognize that for the 1 or 2 that get funded, there's a group of individuals that have great ideas that did not get funded. I review grants, just got done reviewing grants for young investigators. And it's tough, and it's competitive, and it's hard. And when NIH is talking about, reducing their funding line, and that means NCI's got to cut their budget, it's already pretty paltry. Less than 1 in 10 grants submitted gets funded at NCI. And I think to some degree that's not acceptable. I don't know what the answer is. I don't think there are unlimited funds. The other thing for individuals that are interested, we have to realize that if you pay taxes, some of your dollars go to research. They just do. You may not know what, but some of those dollars end up in individuals working on pancreatic cancer. So the way I look at it is my lab really is it's a public lab to some degree. Now, you can't just waltz into the building and go into my lab, right? But we can arrange tours and visits and so forth. And I know you're going to give me a few minutes at the end to talk a little bit more about that. But we do that routinely. In fact, we have one coming up on the 19th. For some students that are going to be touring, undergraduate students. So they recognize, what does a basic science lab look like, and what kind of disease do we study? Well, they're going to learn about pancreatic cancer.
I love it. I love it. Hopefully we can encourage them to stay in the pancreatic cancer field, Dr. Grippo.
Yeah, that's the goal. That's the goal.
I love it. I love it. Well, you nailed that answer. And like I said, there's no right or wrong to it. You bring a life's worth of knowledge into this space, and super excited and to have you as our recipient, to have you in this space. It's been awesome to have you on the podcast. The last piece here, for those that want to learn more about your research, maybe they're in the Chicagoland area, maybe someone from afar is listening to this and is really intrigued to learn more, or maybe, like you said, maybe want to fund your research or one of the great projects you're working on. Where's the best place for them to do that? Is there an email, website? Where should people go?
Well, so there is a website. If you go to the University of Illinois Cancer Center and look up my last name, Grippo, you'll find a nice little splurb about me and another goofy picture of me in a tie. But and the reason I say that is I don't normally wear ties when I go to work. I just I have this issue where I like to put a tie on when I'm talking about anything in regards to data or anything in regards to advancing pancreatic cancer research, or any research for that matter. I think there's something very regal about what we're doing, and I want to respect that. So that's why I donned the tie today. Normally, I go to see the mice in jeans and a t-shirt. Just fair notice, Dino. So, but in regards to reaching out, you could look at that website. That provides kind of a general splurb. Really, reaching out to me via email is perfectly fine. It's pgrippo, PGRIPPO @uic.edu. I'd be more than happy to talk about, like I said, a lab tour. If you got a group of folks that want to come and see a lab, we can arrange that. We'd have to clean it up a little bit at this point. It's gotten a little messy. That happens just like a kid's bedroom, right?
That's all right.
Clean it up now. I don't see the floor, so you got to clean it up. So we do clean it up and make it presentable. We need certain permissions, so it has to be planned in advance. I can't just have it show up the day of. It has to be planned in advance, usually a couple of weeks, so I can get notification to my boss and to some of the individuals in the building in regards to what we're doing. But we're happy to do that. We're also, like I said, I'm more than happy, as you know, to certainly talk about it. Like I said, it's become a lot more personal to me now in light of my cousin's passing. But and Dino, I say this, I'm sorry about your loss. I know it's been a number of years, but it to some degree, that's all. When I was at the wake of my cousin, I felt horrible, because here I've been studying this disease for near 30 years, and I couldn't do a darn thing for him. And his brother, my other first cut, came up to me and said, "You got to keep going." That's what he said to me. And I said, "But I failed." He goes, "No, you don't fail. You got to keep going. Now you got to really do it." And that's what drives, right? That's what drives you. That's what drives a lot of people in this space, is you just got to keep going. You can't go, "Well, let me let off the gas." No, this is not the time to let off the gas. You got to straight away hit it hard. And so I'm passionate about that, and I drive at times hard. I don't drive my staff and those that work with me hard because they're training. That's a different kind of thing. But I do push to get things done, because we have limited time, and every bit of time means someone down the road might benefit from this. And if we slow down or try to, and it's hard. It's hard when you don't have a lot of funding. It's hard when, people come and go. It's a very transitional environment, because you're working constantly with trainees that are only there for a few years and then they're gone. And that's pretty customary to any academic setting. That's not unusual. So anyway, reach out to me. Be more than happy to help set that up, and we can arrange that. And if there's anything, if you have any questions, I do have links to some folks here at UI Health and in the city in general in regards to pancreatic cancer care. If that's something that I'm sure you mentioned, you've got staff that do that and probably do it a lot better. But I'm more than happy for those that are in the Chicago area to offer that as a means of helping them in their dire need.
Well, Dr. Grippo, thank you. It's been an honor to have you on the podcast. It's an honor to fund your research. And it's, as I said, I know to sound like a broken record, it is so inspiring and exciting to hear all the great things you're doing, to have you in the Chicagoland area, to support that community. These conversations that I have, like you say, like, you got to keep going, man. Like, I want to go like run through a wall right now, or like, get the team going, go out into the office and rally the troops, because we've got to raise more to keep funding great researchers like yourself. So thank you for all you do. Thank you for being a guest here on the Project Purple podcast.
Thanks for having me, Dino. Appreciate it.
Thanks for listening to another episode of the Project Purple podcast. If you like today's episode, feel free to share this episode and make sure to follow the Project Purple podcast wherever you listen to podcasts. That's a wrap of another episode of the Project Purple podcast. Until next time, please be safe, and thanks for listening.